So in terms of, would be interesting now to discuss the immune-related adverse events with immune checkpoint inhibitors. Dr. Wang, would you like to discuss the expectations in terms of autoimmune toxicities with cemiplimab?
Sure. So in contrast to cytotoxic chemotherapy and targeted therapies, the side effect profile of immune checkpoint immunotherapies is quite distinct. In general, we may see much fewer serious side effects, not so much cytopenias. The most common side effects with immunotherapies includes some mild fatigue, but generally not to the point where patients are debilitated or unable to complete their activities of daily living. Commonly, we can see some nausea, but again, most of the time patients are requiring any severe antiemetic therapy. Autoimmune side effects resulting from immune activation. The most common ones can be a skin rash that is generally quite easy to manage with topical steroids, and thyroid dysfunction, so either hypothyroidism or hyperthyroidism. So in general, the side effect profile is very mild and very manageable. Of course, with immunotherapies, there is a possibility for very serious, even life-threatening side effects. And so we would need to be keyed in and to evaluating for any sort of autoimmune activation. So pneumonitis, for example, colitis, hepatitis, and the like. But again, those tend to be much less common, and if they occur, tend to be quite easy to manage by stopping the immune therapy and instituting immune suppressants such as steroids.
Thank you, Dr. Wang. Dr. McCain, you discussed how do you monitor these patients in terms of blood testing, pre-treatment, and so on. How about patient education and communication with patients during this treatment?
Mm-hmm. Yeah, so I usually outline ahead, a time of consent with patients, kind of expectations, because I think now that we have a very good understanding of what we as medical oncologists are monitoring for, I think it's always great to inform the patient, because if a patient has initial onset of diarrhea, if they notify your office, you can take prompt management. It's the patients that come in weeks later, those are patients that are severely dehydrated, may have additional complications from their toxicities. And so I think laying out to patients that there can be very serious toxicities, but as soon as you notice any symptoms, call us, let us know, come into the office, because these are generally easily managed with the information provided.
So close communication is very important. They have to call us if they have any symptoms or not feeling well. That's what we stress.
I think it's also important to make your colleagues in other subspecialties aware of the unique side effect profile of these immune therapies. So a patient presenting to the emergency room with dehydration from diarrhea, the emergency room physician needs to be aware that of the possibility of autoimmune-related colitis, as opposed to what they may normally think about as diarrhea related to chemotherapy.
And some places have started an immune-related adverse event board where different subspecialties get together and discuss, which is obviously unique. And again, stresses the importance of, again, the multidisciplinary approach to managing those toxicities. Mm-hmm. So just building on your discussion, Dr. Wang, the phase 2 study in the New England Journal of Medicine reported in terms of grade 3 or more adverse events in about 42% of patients, 29% were considered serious, 5% led to discontinuation of treatment. And these are probably the most serious when it leads to discontinuation. There were 5% of events that actually led to an outcome of death. And again, stresses what we all know, that the importance of close communication, catching these toxicities early on, and initiating management. What was interesting in ASCO of this year is the update, the 12-month follow-up in 59 patients. And this is now a median follow-up of about 16.5 months. The overall response rate was 49.2%. 10 patients achieved a complete response, which is about 17%, and 19 patients partial response, which is about 32%. Again, speaks to the durability of responses with immune therapy as compared to chemotherapy, where we see actually benefits kind of erode over time. With immunotherapy, we see actually durability and kind of maintaining the same level of benefits. In terms of progression-free survival, again, it was interesting in the presentation at ASCO this year that the median progression-free survival was actually 18.4 months as well. Speaks to the durability of these responses. Median overall survival was not reached, although at 24 months, about 70.6% of patients were still alive in the study at 2 years. Exciting data. So as a take-home message, our first-line treatment for patients with metastatic inoperable cutaneous squamous cell carcinoma is anti-PD-1 immunotherapy. We have an FDA approval for cemiplimab. The response rates are exciting, upward of 50%. Most of these responses are durable. Immune-related adverse events are very important to keep in the back of our mind and in the discussion with our patients, stressing close communication between the clinic and the patient in managing these toxicities, and involving a multidisciplinary approach in managing toxicities the way we plan the treatment for the patients.